Good evening, everyone, and welcome to our inaugural Expert Perspectives post-conference highlights on MASLD MASH from DDW. We hope you're doing well. This is a joint collaboration from the University of Cincinnati College of Medicine, the Chronic Liver Disease Foundation, and the Gastroenterology and Hepatology Advanced Practice Providers Organization, brought to you also by a generous educational grant from Novo Nordisk. I'm Dr. Nadej Gunn. I'm a hepatologist in Waco, Texas, and your moderator for this evening's program. Next slide. I have the honor of being joined by two expert faculty and esteemed colleagues, Dr. Rohit Lumba of the University of California at San Diego, and Ho Chung Gillis, a doctor of nursing practice at Richmond VA Medical Center. Welcome to you both, and thank you so much for joining. Next slide. I'd like to thank again Novo Nordisk for supporting the CME activity with an educational grant. Next slide. So just to set the stage, the program overview really is, again, a collaborative educational initiative that is designed to live stream information about meetings that just occurred. So as you know, DDW just ended last week, and we're going to tie in some of the highlights from abstracts that were presented at that conference, especially as they pertain to MASLD and MASH. And we'll continue to do this throughout the year for EASL, AASLD, and ACG, and we hope you can continue to join and glean some really good information. This audience that we're targeting is anyone who has interest in MASLD and MASH and cutting-edge therapies in that realm. Gastroenterologists, hepatologists, nurse practitioners, advanced practice professionals, nurses. If you're interested, this may feed you. Next slide. These are disclosures, learner assurance, and disclaimer. Take a moment to look at this. This was also provided in some of the materials when you registered. Next slide. These are our faculty disclosures and our planning committee disclosures for your review. Next slide. And again, this is an accredited program, and you all are eligible to apply or register for one CME Category 1 AMA PRA credit. We hope that you will, and your enthusiasm about this program, you doing your pre and post test questions and completing your evaluation will continue to allow us to have free CMEs for us all. So please do complete those evaluations and those test questions. Next slide. So these are our educational objectives, and the way we're going to work this evening's program is we're going to highlight from DDW late breakers, oral presentations, poster presentations that specifically speak to these three topics. Number one is we want to know what's new with monitoring of MASH and some of the emerging data on diagnosis. Number two, we want to analyze some of the current and potential pharmacologic management strategies, especially as they pertain to GLP-1 agonists in the management of MASH. And the last objective is how are we integrating weight loss into the treatment paradigm and management paradigm with MASLD and MASH? And we'll talk about some of the abstracts presented at DDW that speak to this topic specifically. Next slide. Here's how to claim your credits. Please go ahead and take a moment, scan this QR code. This will take you to a platform that'll give you all the information you need on how to claim your credits with information about the pre and post test and program evaluation. I'll leave this slide up for a few seconds so you can orient yourselves and get the QR code scanned. Okay, next slide. Okay, so I'm going to go ahead and set the stage and just provide a little bit of a background on MASLD and MASH, and then we're going to go into the discussion. Ho Chung is going to speak to some of the abstracts. We'll break and have a little bit of discussion. Then Dr. Lumba Rohit is going to go ahead and do a few more abstracts, and we'll break for discussion. And then we'll tie it back up with Ho Chung with a last abstract and some more discussion. Remember that on your screens, you have an area to go ahead and enter chat questions. We'd love to hear your thoughts and incorporate them in our discussion as well. Next slide. So as you know, MASLD is a current and growing crisis in the US and worldwide. You'll read different literature and it'll tell you that the overall worldwide prevalence of MASLD is anywhere from 24 to 30%, over 2 billion people affected of all ages throughout the world. Next slide. Here in the US, a statistic from 2018 said that we have about a 25 to 30% prevalence of MASLD, but this is, again, a growing phenomenon. Next slide. Give this slide a moment to build. And as you know, and as I earlier mentioned, MASLD occurs in about 25% of our population. Of those, another quarter will develop MASH, which is the angrier form of MASLD, which is characterized by histologic features, as you know, of fat, the hepatocyte ballooning, and inflammation. And in some individuals, they may progress to develop fibrosis. Of those who develop fibrosis, that fibrosis progresses over time and potentially cirrhosis can develop. And as you know, once cirrhosis develops, now these individuals are at risk for liver failure and/or liver cancer or both. MASLD, as you know, has become the most common cause of cirrhosis in adults. It's the second leading cause of waitlisting for liver transplant in all patients, and the first leading cause of waitlisting and liver transplants in some Asian, Hispanic, and non-Hispanic white females. So clearly a disease that needs our focus and attention. Next slide. Individuals with metabolic disease are at high risk for developing or having MASLD. We know that if you have an obese individual, that is the person that you're looking for fat in their liver. 50 to 90% of individuals who are dealing with obesity have MASLD. Don't forget about the type 2 diabetics. Over 50, 70% of these individuals will also have fat in their liver as well. If they have underlying cardiovascular disease, hypertension, hyperlipidemia, these are the underpinnings of development of MASLD. Also, we know that fibrosis, as it advances, is the single most important phenomenon that is associated with all-cause mortality increase and liver-related mortality increase. So it behooves us to not only identify those with MASLD, those with MASH, we need to know what stage of fibrosis these individuals have. Next slide. FDA implores us to have a histologic improvement to prove that we are doing something when it comes to pharmacotherapies and treatment for MASH. Whether you're in the US or abroad, this definition means that we need to have achieved MASH resolution where we've eliminated balloons, increased inflammation on histology without worsening of fibrosis, and depending on where you are, fibrosis improvement with an improvement of stage of fibrosis at least 1 point and no worsening of steatohepatitis. Next slide. Currently, our approaches for treating MASH are primarily weight management, lifestyle, diet, and physical activity. This is by far and away the foundation for managing this disease. We have weight loss medications, bariatric surgery, some of the incretin hormones, GLP-1 receptor agonists to help us with that condition. Also, in addition, we have to make sure that these individuals have their metabolic syndrome managed optimally to include glycemic control, blood pressure, and cholesterol. And lastly, as far as liver-targeted therapies, we are still working on this, but we were so fortunate these last couple of months to have resmetirom newly approved as a liver-directed therapy for the treatment of MASH in combination with diet and lifestyle. And we also lean on sometimes our old friends, vitamin E and pioglitazone. Next slide. Now, I'd like to take this moment to allow Ho-Chang to discuss some of the emerging data on diagnosis and monitoring of MASH, particularly as it deals with the abstracts that were presented last week at DDW. Ho-Chang, please.
Thank you, Dr. Gunn. It gives me a great pleasure to discuss 2 abstracts, especially since they're from the VA. So next slide. So the first abstract is from Dr. Yo and colleagues reviewing the lean veterans with MASLD having significant greater risk of cardiovascular events and all-cause mortality compared to overweight obese veterans with MASLD. Next. The background, as we all know, are adults with MASLD are at high risk of developing cardiovascular disease and cardiovascular related mortality. However, it remains unclear whether adults with lean versus overweight/obese MASLD have significant differences in long-term risk of CVD and overall survival. And this study was aimed to evaluate the impact of lean versus overweight obese BMI on the incidence of major adverse cardiovascular events known as MACE and long-term survival among US veterans with MASLD. Next. The colleagues here evaluated the CDW, which is the corporate data warehouse from 2010 to 2023, and longitudinally captured data on all veterans receiving healthcare at VA facilities across the United States. MASLD was identified using established definitions. Alcohol use was excluded by audit C scores, and only those that had an audit C of 0 were included in the analysis. And the BMI was characterized into lean versus overweight groups based on BMI cutoffs of less than 25 grams per kilo for non-Asians or less than 23 kilos for Asians. Next. So they evaluated approximately 1.7 million veterans with non-cirrhotic MASLD. 94% of those were men, approximately 66 were non-Hispanic white. 93% were pretty much overweight and 7% were lean. I'd like to go to the next slide, and that way we could talk additionally about the additional results. As you can see on the next slide, next slide, sorry. There we go. As you can see on the panel A, they talk about the cumulative incidence of MACE and also the overall survival on panel B. And as you can see, the incidence of MACE was significantly higher in those with lean versus overweight MASLD. And then the overall 5-year survival, you start seeing the divergence as survival was lower in the lean MASLD veterans. Next slide. And as you can see here, the lean MASLD veterans were also more likely to be greater than 60 years of age and likely have more fibrosis and had an index of a FIB4 greater than 2.67. Additionally, on a multivariate regression, veterans with MASLD had higher risk of MACE and all-cause mortality. Next slide. So among the national cohort of US veterans, MASLD in lean BMI patients was associated with significantly higher incidence of MACE and significant lower long-term survival. And it's important to raise the awareness of why the poor outcomes in these individuals with lean MASLD and address those factors that may improve disparities between lean versus obese overweight MASLD. Next slide. All right, the second abstract here is which is was given the poster of distinction, was reviewing the higher incidence of cirrhosis and hepatocellular carcinoma in lean versus overweight obese veterans with MASLD, and also from the same group. Next slide. The background was this study was aimed to evaluate the impact of lean versus overweight obese MASLD on long-term incidence of cirrhosis and HCC in a cohort of US veterans that were non-cirrhotic MASLD who reported no alcohol use. This is the same cohort that was described in the previous abstract discussed, and the veterans who reported no alcohol use were included in the cohort and had to have an audit C score of 0. The cohort was stratified into lean and overweight groups based on the established cutoffs as discussed in the previous abstract. Next slide. So as you can see here, the incidence of cirrhosis and HCC were higher in patients with lean versus overweight MASLD. And also on the right, on a multivariate Cox regression, patients with lean MASLD, although had a significantly greater risk of developing HCC, but overall, the differences in the risk of cirrhosis were no longer significant. Next slide. So among a large national cohort of US veterans with MASLD, lean MASLD significantly had higher incidence of cirrhosis and HCC that was observed, and also that there is an urgent need to better understand how and why the associated comorbidities influence the progression of non-cirrhotic mast cell D to cirrhosis and HCC, and improve the quality of care and outcomes among those with lean mast cell D.
Next slide. Thank you so much, Ho Chung. That was very nicely articulated with those two wonderful abstracts, really highlighting lean MASH. Rohit, I'd love for you to help us here. Are we missing something in the diagnosis of lean Maselden MASH? Is there something we should be looking at a little bit closer? Because we really do spend a lot of time focusing on the obese population.
Yeah, no, you're absolutely right. By the way, both of you did a fantastic job and really helpful in understanding, first of all, setting the stage by you, Nedaj, and then Ho Chung brilliantly discussed the two abstract. Lean NAFLD, there's some new things that are happening. And one area that I want to bring your attention to is the role of genetics. So why would a lean person develop same degree of liver disease that usually is associated with obesity or diabetes? And that's in the setting of possibility that there are genetic traits that are influencing. You could have common variants that are associated with fatty liver, maybe overexpressed. So if somebody is PNPLA3 homozygote, they also have TM6SF2 or other risk alleles associated with steatosis and steatohepatitis. So that would be one idea. The other idea could be that you have rare variants that may be causing fat deposition in the liver because of this monogenic disorders. And the new classification that we have, or the nomenclature with steatotic liver disease, allows us to think about those, but it doesn't allow us to think about lean versus non-lean. So those patients with monogenic disorders, or those patients with a disease area that could be related to a complex genetic trait with multiple genotypes contributing, it will be in different areas within the SLD framework. So I think it's important to think about that. Other things to consider are, of course, medications that patients may be exposed to, or baseline disease. For example, diseases such as IBD, there's an increased risk of having hepatic steatosis. Diseases such as psoriasis, psoriatic arthritis, the risk is higher as well. And then lastly, thinking about alcohol, because many times we are asking history based upon audit, but it may not fully classify our patients. So if we are thinking that this could potentially be alcohol, we are more and more using in our practice PEth assessment, which is a quantitative biomarker of alcohol consumption over the last 2 to 4 weeks or so. So all those could potentially be helpful.
That was very nicely said, Rohit. Thank you for gleaning some light, especially on the genetic risk factors of these individuals. When it comes to practice, though, what do you do differently, I guess, in your lean individuals? Is there something that they have or a particular characteristic that they have that tells you, I need to screen?
Yeah. I'll give you an example. If I have a lean patient, and by lean, I mean BMI that is below 25, and for an Asian patient in my practice, a BMI below 23. In that setting, if I see significant fibrosis, say stage 2, stage 3, I'm thinking about genetic influence. If I have patient who has milder disease but has a BMI below 25, I'm also thinking about maybe they have some sort of a predisposition, family history, things of that nature, and I seek that out. In terms of treatment, there is data based upon Piven's trial. You mentioned something about vitamin E. Patients do respond to vitamin E, and their response to therapy is no different, whether they're lean or obese, obesity-associated steatohepatitis. So I think you could consider other therapies in them, including vitamin E, pioglitazone. Another category of diseases that are important where we actually have therapies is lipodystrophy. So lipodystrophy is something that could go unchecked, and again, if you think it could potentially be genetic, then one could identify that clinically. Typically, patients with lipodystrophy have very lean extremity, but their abdomen has a large hepatomegaly, and so you could identify those patients. Then I also see patients with HIV and steatosis and fatty liver, and sometimes I find them to have a lower BMI. So if you have another hit that is associated with liver disease, you may see a lower body mass index, ruling out alpha-1 antitrypsin related deficiency with phenotype or genotype testing, and another idea that one could consider in that patient population.
Excellent. Ho Chung, is there a treatment that you would particularly utilize in this individuals, especially now that we have a newly approved medication? Would that be something you'd consider in a lean individual with MASH?
Yeah, because I think that's a great question. As you know, resmetirom was approved for, fibrosis stage 2/3. And I think that, regardless if you have a lean MASH versus an overweight, patient with MASLD, that we all know that, when they develop fibrosis, that's really their increased risk of developing liver-related mortality. So especially in the F2. So regardless of the BMI, if their fibrosis stage is 2 or 3, we recommend treatment.
Excellent. I really think this was nice. Thank you for summarizing the abstracts. Lean individuals often get forgotten because even in the guidelines, they say obese and the lean folks just get tossed to the side. So we really need to spend some time. This was very nicely done by Wong and colleagues to shed some light on our lean individuals. I'd like to move on unless there are questions from the audience. And allow you, Rohit, to really help us here understand some of the new pharmacologic treatments, especially with the rave around incretin hormones and GLP-1. What's all the jazz? Take us through the DDW abstracts and help us understand. Next slide.
Thank you, Neeraj. So the first, it's okay, we can go to the next one. So this abstract is related to survodutide. This is really important data. We're going to look at histology data that'll be presented at EASL, and there was a press release as well earlier this year. This is looking at the interim analysis of the randomized double-blind placebo-controlled phase 2b trial with survodutide versus placebo, looking at liver fat content, presented by Dr. Naeem Alkhouri and colleagues. Next slide, please. So if you look at GLP receptor analogs or GLP-1 analog, which are to the left here in the schema, and then glucagon receptor agonist or glucagon analogs are to the right. What are the key sort of mechanistic pathways that are associated with GLP-1 analog? GLP-1 activation leads to increase in insulin secretion, and this predominantly happening at the level of pancreas, leads to glucose-dependent insulin secretion. This leads to reduction in body weight, which leads to improvement in hepatic steatosis. There are no GLP-1 receptors in the liver. So the improvements that we are seeing in liver physiology and liver pathology are related to indirect effects of GLP-1 analogs on liver. We also know that it affects central nervous system, reduces appetite through its action on hypothalamus. This leads to reduced food intake, leading to weight loss. We also know that it has GI tract effects on motility and reduces gastric emptying. When you don't empty your stomach, you will still be full. This will further lead to a reduction in caloric intake. You'll be full earlier, and then you'll be full longer. And this leads to further reduction in body weight. Together, this leads to improvement in obesity, as well as rates of type 2 diabetes, and overall then leads to improvements in hepatic steatosis and steatohepatitis. Glucagon, on the other hand, is a stress hormone that basically resets your metabolic activity. What happens at the level of adipose tissue, it increases lipolysis. And at the level of liver, it has a direct action on the liver, and glucagon receptors are present. What happens is that liver fat that is there in the liver gets converted into glucose. And so it increases hepatic gluconeogenesis. You can imagine then you have a GLP-1 analog tied to it that helps by taking care of that glucose because you have increased insulin production at the same time with GLP-1 agonism. So combined, these two therapies work very well. You got the yin and the yang, and together they're able to improve steatohepatitis, and in this particular case, liver disease. We have known data that if you have GLP-1 alone, you will have a certain liver fat reductions. We have data across the board. If you added glucagon agonism on top of GLP-1, you will have greater liver fat reduction based upon the mechanism that I just mentioned. Next slide, please. Now that we've understood the mechanism, why are we adding glucagon agonism on top of GLP-1? We look at the study design for the survodutide phase 2b trial. We had more than 240 patients age 18 to 80 years who had NAS of 4 or higher, stage 1 to 3 fibrosis, and were BMI of 25 or higher. They also had an MRI PDFF at baseline, week 0, and then at week 28. Patients were randomized to 3 doses of survodutide, sub-Q weekly, 2.4 milligram, 4.8 milligram, 6 milligram, versus placebo. Patients were followed for another 48 weeks and then underwent biopsy. That data will be presented at EASL. So primary endpoint is histologic improvement in MASH without worsening of fibrosis after 48 weeks. Interim analysis is what was presented at DDW, liver fat reductions of 30% or greater versus placebo. This is based upon the work that our group had done for many years. The first 3 studies on MRI PDFF conducted at UCSD, and we came up with the rule for PDFF response, which is 30%. Why is that? Well, 30% reduction in MRI PDFF is associated with higher odds of NASH resolution, 5 times higher odds. So if we see that, we move the drug forward to a phase 2B from a phase 2A. This is a combined 2A and 2B in one study, as you can see. Next slide, please. These are the results on the interim analysis. You can see that we're seeing a pretty robust reduction in liver fat compared to placebo. The number of responders are approaching 91% and range from 87 to 91%, which is very good. And this is what you would expect with survodutide. You can also see that you're getting about the same effect from 2.4 that you could get from 6 milligram in terms of 30% reduction. Next slide, please. When you look at relative liver fat reductions, here you can see that there is a jump as you go from 2.4 to 4.8, but then you're not seeing that further increase, but you can also see the N here is 33 to 27 to 23 patients in the higher dose group and 32 in placebo. What happens with GLP-1 analogs as well as the combo, when you combine a drug on top of GLP, you are also adding some of the side effects related to that drug. And that's why the higher the dose you're going, you're also seeing the N is dropping. And that might be the reason that there's dropout, which we will see as we go through these slides. But that's typically what we would see. Next slide, please. So key summary of finding is liver fat reduction is pretty significant or robust. We also see improvements in ALT and AST. We see improvement in body weight about 12.5%, improvement in hemoglobin A1C of 0.8%. There are improvement in fibrosis markers such as PRO-C3 and ELF, which is significant. 25% reduction in PRO-C3 and a 0.8 on ELF. That's significant, based upon what we know from other studies. Discontinuation rate. You can see this is what I alluded to. At the 6 milligram arm, 26% in the trial setting. This is on the higher side. Typically with GLP-1 alone, we're looking at 15 to 20%. That's what we were looking at 4.8 milligram at the 17%. So what kind of side effect? Predominantly, they're GI adverse event, nausea, vomiting, abdominal fullness. Some people have initially diarrhea, later on can have constipation as well. But overall, no liver safety trends. Next slide, please. So this was, I think, an important paper that we had at DDW, and we will have more to come at EASL. And hopefully we can get back to you and discuss that. and you'll be interested in learning about it. This is looking at GLP-1 agonists on cirrhosis, HCC, and mortality. We've got two abstracts that are similar. We'll discuss both of them. This is coming from first author Aditya Sood from Northwell, as well as colleagues from Stony Brook and Yale, and Dr. Sanjay Satyapati as well. Next slide, please. Of course, we understand, NASH is a major, liver disease, and we see increased rates of cirrhosis, hepatocellular carcinoma, and significant healthcare costs. In this particular study, they looked at two cohorts, TriNetX and US Collaborative Network databases. They had 8,000 or so patients who had NASH classified based upon some criteria that they came up with. Of course, these patients don't have biopsies, were on GLP-1 analogs. And then there are other comprising NASH patients not using GLP agonists. That's 36,000 or so of them. Cohorts were matched for age, race, sex, diagnosis using propensity score matching. And they looked at key outcomes including cirrhosis, HCC, and mortality. Next slide, please. So, what they found was those who were receiving GLP and had suspected MASH within this population compared to those who were not receiving GLP, they had significantly lowered the risk of developing cirrhosis. And at year 1, and also year 5. MASH plus GLP also had significantly lower risk of developing HCC. Mortality assessment for these two groups also showed a protective benefit where patients with MASH, GLP had a lower likelihood of mortality at 1 year, with that gap widening at year 4, 5. Okay, what are some of the issues? Why do we always see such clean, crystal clear data in retrospective studies? And then we start doing prospective studies and now we're waiting for outcomes and we don't see that big treatment effect delta. And it's really about the one bias, which is what kind of patient would you treat with GLP analog and what kind of patient you won't? So I think it's this bias, which is the treatment index starting or initiation bias that's always there in a clinician's mind. And when we are looking at retrospective studies, we're never able to eliminate that bias. So I want you to always understand that. And using retrospective data, we use this to develop hypotheses to design randomized placebo-controlled trial. But I don't change my practice based upon something retrospective because I know that a patient who walks into my clinic and starts GLP-1 analog is different than somebody I don't because they may have other comorbidities. They may have other things. What do you get with type 2 diabetes that's been going on for a very long time? Patients may have really bad gastroparesis. That patient with bad gastroparesis, I would be less likely to start. And that same patient is probably older. They're 70. I don't start GLP-1 analogs in a 70, 75-year-old. My dad is 83. I'm not going to start him on a GLP-1 analog. But who is more likely to be closer to cirrhosis or hepatocellular carcinoma? Individuals in their late 70s and 80s. So now we're looking at 1 year and 5 year outcomes. It's clear. And you can say, oh, we match with age, but matching always doesn't take care of what implicit bias is going in when, as clinicians, we're deciding which patient to treat with which medication. So with that, let's move on to the next slide. So this is the data from this particular study. It's a very nice study, very well done, and I really liked it. But I just wanted you to be aware of pointing out some of the caveats associated with understanding these data. So clearly improvement both in cirrhosis, HCC, and mortality as well with GLP in this subgroup of patients. Next slide, please. So it's a big study, but it's retrospective, and we're showing positive data on all aspects related to it. So something to keep at the back of our mind, but of course we have prospective data coming from Essence, where we'll look at future risk of progression to cirrhosis in patients with NASH stage 2 or 3, and potentially with larger studies, a look at future risk for hepatocellular carcinoma as well. I do think they're beneficial. I think the treatment effect deltas are not that significant as they're shown in retrospective studies. Next slide, please. This is a systematic review by Mahmoud Mahdi and colleagues from University of Kansas School of Medicine, looking at GLP-1 agonists and NAFLD, looking at screening and treatment. Next slide, please. So, if you look at the guidelines, we, of course, use GLP-1 analogs for treatment of obesity and type 2 diabetes. But the trials are still underway for treatment of NASH-related fibrosis. And we don't use GLP-1 analogs currently for treatment of NASH-related fibrosis. I think that's really important to understand. So here they looked at systematic review to look at these trials using GLP-1 analogs in the setting of liver fibrosis and long-term clinical events. Next slide, please. So it's a modeling exercise. They were looking at patients' NAFLD resolution and groups taking GLP-1 agonists in the early stages of fibrosis, stage 1, 2, and 3, and meta-analysis of patients without stage 4 showing a significant relative benefit for resolution of NASH and much lower risk of progression of fibrosis. Absolute risk reduction was 36% for NAFLD and 17% for fibrosis. Among patients with stage 4 fibrosis, there was a trend towards harm. Cohort study after 13 to 22 years of follow-up found a 67% relative reduction of liver-related clinical events. So they're looking at that you could reduce progression of fibrosis, could occur up to 23% of untreated patients and only 6% of treated patients with GLP-1 analogs. And then the clinical liver-related events would be much lower at 0.4% of treated versus 4.1%, so even 10 times higher. Again, I think this risk is accentuated given sort of the pooled data and its effect, but I think potentially giving us indication that this could potentially be beneficial because we know that obesity, weight gain, and progression of insulin resistance will drive, and hyperinsulinemia is going to drive liver disease progression over years. But it takes about 1 to 2 to 3 to 4 decades for NASH to progress to cirrhosis. Next slide, please. Conclusion, I think this provides us data that GLP-1 analogs would be potentially benefit, particularly in early stages from stage 1 to stage 3. Stage 4, we conducted a study, we presented at EASL and published last year in Lancet Gastroenterology and Hepatology in those who had cirrhosis use semaglutide. The drug still works, but we don't see improvements in NASH histology at 1 year. It could be that if you had cirrhotics, you would need longer-term treatment. And now we have data thinking about combination approaches in those with cirrhosis or long-term treatment, maybe 3, maybe 5 years, and see if we see any improvements. Next slide, please. This is looking at GLP-1 usage and risk of HCC and MASLD population who also have type 2 diabetes, so slightly different cohort. First author Abdullah Sohail, and last author is Dr. Kyle Brown from Iowa, as well as West Virginia. Next slide. So I think the key thing is looking at GLP-1 in the setting of MASH plus type 2 diabetes. That's the patient population, how it is different from the previous cohorts. Next slide. Again, retrospective, time to event, similar database. They use TriNet, electronic health records, 120 million individuals, January 1st, 2005 to December 31st, 2022, like the 18 and older with both type 2 diabetes and MASH being suspected, with and without GLP-1 analogs. Looking at history of HCC, liver transplant, and other events. Next slide. So they found about 15,000 patients or so. Incident HCC was 3.94% in the GLP-1 group and 4.77 in the non-GLP-1 group. So there's a protection if you're on GLP. And this is after adjustment for age, gender, ethnicity, obesity, hypertension, cirrhosis, alcohol-associated liver disease, viral hepatitis, background medications. And then they looked at the protective effects could potentially be related to factors that promote steatohepatitis, and then improvement in glycemic control and weight loss reduced or mediated that effect. Next slide. So I think we learned a lot, and I'll hand it back to our quarterback here, Dr. Gunn.
Rohit, that was beautiful. Thank you. And I think, as evidenced by the chat, everyone's lighting up. They have lots of questions. So this discussion is going to be quite robust. There was actually a question back at the lean mash section that I will get to in a minute. But I want to ask Ho Chung, especially with the last abstract that Rohit presented, are you compelled at all to potentially use a GLP-1 as a prevention of HCC, as a chemo prevention in a sense? Tell me what your thoughts are.
Until there's more data, I don't know if, plus with the criteria for use in my setting, I'm probably not the best person to ask because, and because of the related costs, I doubt it unless they're better studies. But I'm very restricted in the VA system, so.
Well, that's an honest, practical approach. What about you, Rohit? Would you consider that data compelling enough? What do we have anyway to prevent HCC? We just know to screen for it, right?
Yeah, I think, it will be really good to do a big chemopreventive trial. One of the studies that we are doing in the liver cirrhosis network that I'm part of, along with several colleagues across the United States, looking at statin use, and we are looking at rosuvastatin. There's another statin study happening at VA with simvastatin. So I think those are credible efforts to see if we could reduce future risk for HCC or future risk for liver decompensation. There is some data on metformin. Again, we will want to validate that in a future study. GLP-1 analogs, I think, are potentially, you could consider. But again, I think the time duration for the HCC chemoprevention study is very long. Hopefully that can be addressed through larger studies that have been done where we can log in the patients now and then look for, future outcomes in them because it's much easier to adjust now, even in the setting of a database, and then follow patients rather than over adjusting at the back end. But I won't use any of these drugs for chemoprevention. I have some other ideas about chemopreventive approaches as to what might be driver of HCC. In some cases, DNL, de novo lipogenesis, is how cancers basically generate energy themselves. If you were to block that, you could potentially have reduced carcinogenesis. So that would be some of my approaches to consider.
That's great information. Thank you for enlightening us on that. The survodutide data was quite interesting, especially with that PDFF drop. Would you consider the GLP-1 strictly for the fat resolution or the fat improvement? I mean, we're clinicians here. We got to make some choices. Sometimes they're outside of the box. So will you or will you not consider a GLP-1, especially in an individual who's not already on one, just for the decrease of the fat in the liver? Because we know that there are histologic, downstream histologic benefit when that PDFF goes down.
Yeah, I think the key thing here is that with semaglutide GLP mono analog, you will see improvements in liver fat reductions and then NASH resolution. With survodutide, because of the glucagon action, you could see improvements in fibrosis. So we'll see that at EASL if the improvement in fibrosis are seen, because then you can think about taking that extra side effect for the sake of improving your liver fibrosis at the same time as NASH resolution. I think that's the sort of the trade-off.
Mm-hmm. Your thoughts, Ho Chung?
I completely would not disagree with Dr. Lumba. So, but there, and for those that are going to EASL, I'm jealous. So, hopefully, I'd like to see that data, and I'll tune into the next perspective to get the catch up on that. So.
Okay. I think this ties into a question from L. Koblenz on the chat. Semaglutide is well known to reduce steatohepatitis without worsening of fibrosis, but not a significant effect on fibrosis reduction. What is the effect of survodutide on MASH fibrosis? I think you mentioned that, Rohit, but do we have that data yet, or are we waiting on it?
There was a press release from Boehringer Ingelheim that showed that there was a significant improvement in NASH resolution. They provided the rate was 83% versus placebo. The fibrosis improvement data was not in the abstract, but it was written that it is significant. So we don't know what exactly is the treatment effect delta on fibrosis improvement, but I think we will see that at EASL.
Okay, excellent. This is a question that goes back to our lean MASH section. We did mention, and you did actually, Rohit, that you would consider vitamin E in the lean individuals. But Gabriella mentioned, well, what about pioglitazone in the lean MASH? Especially we know pioglitazone might beef them up a little.
I think pioglitazone can definitely be used in that setting, and we've used it. Another thought with pioglitazone, you could, although there isn't any data on cirrhosis, but that would be a good, again, chemopreventive strategy to consider as a RCT in the setting of cirrhosis. Currently, we don't have any treatment. A lot of our patients do lose muscle and also body weight as they progress their cirrhosis. So it's possibly you could use even later on, but the studies need to be done. But definitely you could use that in lean.
I see you're nodding your head, Ho Chung. Have you used that in that population? Yes?
Yeah, I mean, we don't see, again, the proportion that we're reporting the studies in the VA system. I think it correlates to clinical practice. Majority of the patients that we see are the obese, overweight, but there's definitely a role for pioglitazone in the lean MASH patients for sure.
Excellent. And you nicely highlighted, Rohit, all these abstracts that point to GLP-1s as preventative and potentially decreasing all-cause mortality and untoward outcomes in our patients. Amanda from the chat asked, how would we change our HCC screening guidelines, especially if a GLP-1 or one of its cousins hits?
So HCC screening is really for in the setting of NASH is those who have cirrhosis. And so I don't think we need to modify our HCC screening and surveillance guidelines. In fact, if we were to use GLP-1 analogs, we would reduce the risk. So, we would be doing less of it because less people hopefully will progress to cirrhosis. But currently, I think a lot of people have undiagnosed cirrhosis in the setting of type 2 diabetes and in the setting of obesity. So I think we need to just make sure we get those patients who may have pretty high liver stiffness and go and screen them. So I don't think based upon GLP-1 analog uptake that we would have to modify our HCC screening guidelines because those are dependent on diagnosed cirrhosis.
One of the last things you mentioned is that I believe it was the most recent abstract you presented, that it showed a trend toward harm in F4 populations. How does that resonate with you? Are you using GLP-1s in your established cirrhotic or cirrhosis individuals? I know there are studies that show no harm. There's some data around PK values in cirrhotic individuals with no issue, but tell me what your practice is, and especially in cirrhosis.
Yeah, I think I don't use or recommend that in the setting of decompensated cirrhosis. Many times when you have the database type studies or pooled analyses, sometimes people are wrongly treated, and it could be that the harm is mainly in those who have decompensation. And so I think that would be the problem. The other thing is, we know that a gallbladder event it can be catastrophic in a cirrhotic. And so, you want to be careful in the setting of cirrhosis where you could precipitate a gallstone and a gallbladder, event related to choledocholithiasis or pancreatitis or cholecystitis. And that can be pretty dramatic in a cirrhotic. So I think those would be the caveats. So avoiding that. So if you were to use it, I think gradual weight loss would be the way to do it. and making sure the patient is not precipitating a gallbladder event.
What comments do you have, Ho Chung? Are you steering away in this population, in this setting?
Yeah, I am, especially, you know, it's a no-go for us for decompensated cirrhosis anyway. They often are sarcopenic, so that, you know, we need to see, which we'll talk about in the next abstract about, you know, the fear of reducing skeletal muscle mass, especially in patients with decompensated cirrhosis. But if anything, you know, endocrinologists, you know, tend to treat those patients, but they don't know that they are cirrhotic, as, you know, Rohit was saying. But I think that I would be cautious to initiate it based on histology.
Excellent. And I appreciate all your comments. We're going to go ahead and take it to the last and final section. Ho Chung, if you could kick us off and talk to us specifically about that skeletal muscle and weight loss in this final abstract at the DDW.
Yes,
Next slide, please.
Right. This abstract, you know, is in the section of integrating weight loss into MASLD/MASH disease management strategies. Next slide. This abstract is from Dr. Fogla and his colleagues and Sanil Kumar, where they examined the use of semaglutide and how it achieved weight loss and fat reduction with preservation of skeletal mass in patients with MASLD, and it's a retrospective longitudinal study. Next slide. I think we all know that semaglutide, a GLP-1 receptor agonist, has been, you know, shown to reduce weight and improve steatohepatitis in patients with MASLD. But there is a growing concern that this medication is associated with the loss of muscle mass, which could be important in our cirrhotic patients. Despite the prevalence of semaglutide use, less is known about the longitudinal changes in body composition indices in patients with MASLD taking semaglutide. So next slide. So next slide. So the inclusion criteria in this longitudinal study were patients that were with MASLD that were confirmed by transient elastography that was seen in a multidisciplinary clinic between October 2019 and April 2023. They looked at primary outcomes and change in body composition indices via bioelectrical impedance or in-body analysis in patients on semaglutide were compared to those that were not on semaglutide. Primary endpoints also included change in total percent body weight, skeletal muscle index, which is SMI, and skeletal muscle mass and truncal fat in pounds. And then the secondary endpoints included change in BMI, absolute weight in pounds, liver enzymes, fibrosis, and steatosis measurements on elastography. And the measurements were taken at baseline, 6 months, and 12 months. So, and then next slide. So they enrolled 135 patients with MASLD, and 69 were on semaglutide, so about 50-50, 66 were not on semaglutide. And I will go ahead and go to the next slide to discuss the key results from this abstract. So as you can see, at 6 months, there was a greater percentage of semaglutide group that achieved a 10% total body weight compared to the control group where they were not on semaglutide. That was statistically significant. And next slide. So there was also a greater reduction in truncal adiposity and skeletal muscle mass, including the indices of skeletal muscle mass and the skeletal mass index that was seen at 6 months. And at 12 months, you see a reduction in skeletal muscle mass and skeletal muscle index that was similar between the groups. So there was no real statistical significance between the two groups, but there was difference in the truncal adiposity that remained significant at that 12-month mark. Both cohorts really showed some reduction in steatosis, as you can see in the CAP scores at 6 and 12 months. And compared to those that did not, were not on semaglutide. And at 12 months, it was important to see that semaglutide was associated with greater reduction in fibrosis compared to the control group. Next slide. So the study demonstrates the ability of semaglutide to achieve significant weight and truncal fat reduction in patients with MASLD while preserving skeletal muscle indices over a 12-month period. Additionally, semaglutide may also, as we all know, play a role in improving hepatic steatosis and fibrosis. And that is the last.
Thank you, Ho-Chung.
And
I must say we have to appreciate this work because they're supporting that potentially the weight loss and the muscle was preserved, fat was reduced, and that's great. But we all know in clinical practice we've had patients who've lost a enormous amount of weight and lost muscle. So is this data compelling enough for you to say, well, I don't need to worry about sarcopenia, resistance training, protein intake? Tell me what your thoughts are. Rohit, we'll start with you. You're muted, Rohit.
Yeah, I think sarcopenia is important, particularly in our patients with advanced fibrosis and cirrhosis. The most important thing that works for sarcopenia is, of course, nutrition, but I think exercise. And in the exercise, some sort of a resistance. But I typically start with assessing what my patient's functional status is. And then based upon that, talk about prescribing, steps and assess how many they're doing, 4,000 or so typically patients may be doing or less, and see if I can get them above 5,000 and slowly get them above 8,000. And then when they come back at follow-up, gradually increase it. You don't want to do that, hey, start doing exercise 3 times a week, 30 minutes, this and that. It's just not practical. You have to see where they are and then get them slowly, to able to increase their exercise gradually. In terms of the diet, I think protein intake is helpful. But again, it's possible that protein intake can lead to increase in body weight. And so you have to be, you have to see and meet the patient where they are, depending on the stage of their fibrosis. Majority of patients who are early in their disease state, typically we're going for caloric restriction, and that's typically, low carbohydrate diet. And so we can adjust that a little bit. But I think it's over long term, you'll see patients you followed for 5 or 6 years, and suddenly they come and they've lost so much muscle. That happens particularly as our patients, get into their 70s. And then, making sure at that time they may actually have to increase their caloric intake, particularly protein intake. And typically I recommend that they start, having egg whites or boiled eggs for that. And that's usually helpful.
So clearly the abstract, although it showed no real loss in the muscle over a year, we know that this is a phenomenon that takes time, and we definitely don't want to discount what we're doing for muscle building. Thank you, Rohit. Ho-Chung, did you have any other comments you'd like to make about that abstract or your practice?
Yeah, thank you, Dr. Gunn. I agree with Dr. Lumba. I think that the data is somewhat encouraging because I think there's still growing concern and about the issue of sarcopenia. I think that, in our comprehensive metabolic liver program, it's important that other key players that, are not the traditional hepatology providers, which is our nutritionists. We actually have a kinesiotherapist or a physical therapist that work with us because that they could tailor, exercise regimens and balance, because there's just so many things that you're juggling in the air, right? You're trying to manage their underlying liver disease, but at the same time, you have to address their cardiovascular disease risk factors and also their activity, their nutrition, and their lifestyle, So it really takes a huge group effort, and right. Very team-based and multidisciplinary team-based is where you're going to see some success. But I am encouraged by the data, but there are certainly a lot more studies that need to be done based on skeletal muscle mass.
Thank you so much, Ho Chung, for those comments. Very well taken. I'd like to thank our faculty, Rohit, Lumba, and Ho Chung Gillis for their time and their expertise this evening. Don't forget to claim your credits for this CME program, and your feedback is encouraged. These posts and pre-tests are available. Please take them so more programs like this can come your way. There are no further questions, so we're good to close out. So we hope you have a nice evening, and thank you so much for joining us.